Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit Podcast.
Welcome back, listeners, to the MedEdit Podcast. I'm your host, Dr. Cari Sorrell, here with my co-host, Dr. Jessica Gray, for another great episode bringing you medical facts without misinformation.
We have a great show today focusing on a topic that has been in the news, especially over the last 5 years. We are talking about the opioid epidemic. And more specifically, we are talking about appropriate pain management.
The number of opioid-related deaths has been rising since 1999. Drug overdoses are the leading injury-related death in the United States and appear to have accelerated during the COVID-19 pandemic.
For this reason, preventing opioid misuse and dependence is critical through education.
For our medical listeners, this episode, Continuing Medical Education Credit, does satisfy the DEA and Texas Medical Board requirement for opioid education credit.
For our non-medical listeners, this episode will describe best practices for controlling pain, non-opioid, and alternative treatment options for pain, in addition to safe, controlled use of opioid drugs.
Even if you yourself are not in pain, this information is highly beneficial, and understanding the proper management of pain can help fight back against the opioid epidemic in the United States. So let's get started on this important topic.
In 2022, 107,941 people in the United States died from drug overdoses, which equates to 296 overdoses each day. Among those, nearly 76% of overdoses involved an opioid drug. The year before that, in 2021, 220 people died each day from an opioid overdose in the United States. That is 220 people per day died. Now, some of you may be already thinking, this does not apply to me. I don't take drugs. I'm not a chronic pain patient. But more recently, the news has been flooded with stories about unintentional overdoses in teenagers and children with the opioid fentanyl. So let's talk about what fentanyl is. This is a hot topic. Fentanyl is a synthetic opioid that is 50 times stronger than heroin and 100 times stronger than morphine. It is a major contributor to fatal and non-fatal overdoses in the United States, and that is why we're discussing it today.
Today on the show, we are bringing in pain expert Dr. Shiraz Yazdani to help us break down this complex topic and provide solutions to pain in a responsible way. Dr. Yazdani is a graduate of The Ohio State University College of Medicine and completed his residency in anesthesiology and internal medicine at Texas Tech University Health Science Center in Lubbock, where he was chief resident. He completed his fellowship in pain medicine at the University of Texas MD Anderson Cancer Center in Houston. He currently works in Lubbock Spine Institute, where he provides both comprehensive and conservative pain management care. He's board certified by the American Board of Anesthesiology with added qualifications in pain management. Dr. Yazdani has extensive experience in the treatment of cancer pain as well. He believes through effective pain management, patients reduce their pain and return to more active and rewarding lifestyles. Welcome to the MedEdit Podcast, Dr. Yazdani.
Thank you so much for having me. I'm so excited to be here with you guys to educate our patients and our loved ones and the public about this increasingly important topic.
Basically, with that long introduction, he is our amazing pain expert. We are so thrilled to have you here.
Thank you.
Yeah, and we're also thrilled to send our patients to see you.
Yes, absolutely. We
utilize
you.
I appreciate it.
All right. If it's okay with you, let's start off by discussing the most recent concerns making headlines and every parent's nightmare: illegally produced fentanyl. As some background for our listeners, there are two types of fentanyl: pharmaceutical fentanyl and illegally made fentanyl. Both are considered synthetic opioids, which means they're made in a laboratory. Pharmaceutical fentanyl is prescribed by doctors to treat severe pain, especially for after surgery or for advanced stage cancer. However, most recent cases of fentanyl-related overdoses are linked to illegally made fentanyl, which is distributed through illegal drug markets for its heroin-like effect. It is often added to other drugs because of its extreme potency, which makes drugs cheaper, more powerful, more addictive, and more dangerous.
Even in small doses, the drug can be lethal. There have been reports in the news of children and teens with fatal accidental overdoses of fentanyl. Drugs may contain deadly level of fentanyl, and you wouldn't be able to see it, taste it, or smell it. Dr. Yazdani, as a parent, this is something we now must think about. We never even thought we'd have to have this discussion. We worry, what if my child was at a party and was given something that they thought was innocent, like ibuprofen, but it was laced with fentanyl? As an anesthesiologist and our pain expert, what are your thoughts on news stories like this that you hear?
Honestly, it's frightening. So when we send our children to school or out into the world, we always assume, obviously, that they're going to be as safe as possible. But a lot of these fentanyl mixes that are coming out now are being put into all kinds of different medications. One example that I'll mention is a parent named Stephanie Turner. She's from Austin, and she tragically lost her 19-year-old son, Tucker Rowe, to a fentanyl overdose poisoning. And he bought an illicit pill off of Instagram and didn't know that it had fentanyl in it. And unfortunately, he passed away from that. And so she's actually started a nonprofit called Texans United Against Fentanyl. And last year at the Texas Pain Society annual meeting, she actually got our Shada Hill Public Policy Award. And she gave a wonderful overview of the organization. She essentially travels and educates the public, schools specifically, about the dangers of fentanyl and what we can do to protect our children. In terms of federal and state laws, there are multiple bills that have already come into effect or are in process right now to help protect us against this dangerous medication. So on the federal level, one of the things that we're trying to do is legalize fentanyl test strips, right? So those are strips that you can use to test a medication to see if it's been laced with fentanyl. And so in Texas, it's been a little challenging. So in Texas, fentanyl test strips are still classified as drug paraphernalia. And so they're considered illegal and you can't purchase them. So in the last legislative session, Texas House Bill 362 was there to decriminalize these fentanyl test strips and remove them from that category. And it got support, bipartisan support, and Governor Abbott supported it as well. Unfortunately, it died in the Senate. So we are very hopeful that in this upcoming legislative session, we're able to pass this so we can get patients or the public in Texas access to fentanyl test strips.
What are they worried about with the fentanyl test strips? Why would they consider that drug paraphernalia for a novice like me?
No, it's historically, it's just been classified that way because it's under that fentanyl drug category. And so we're trying our best. And as a Texas Pain Society member, we are very heavily involved in trying to pass this legislation. I would encourage all of our physicians out there to get involved as well, because this legislation, obviously there are multiple bills that affect healthcare. This affects the public and as you mentioned, our children. And so getting involved with Texas Medical Association, your local county medical society, going to First Tuesdays, speaking with local legislators, those are all critical in order to get these bills passed. Because when you talk about senators and representatives, they're not healthcare professionals. And so that's part of the issue is if they say, oh, this is involving fentanyl, we shouldn't pass this. It takes someone like us to go up and speak to them and say, no, this is what this test strip can do. And this is how it can save lives. And so it's critical for us to become involved on the state and national levels.
I think that's really important to know because even as a physician now, and even when we did our research preparing for this episode, the CDC on their website is like, just get the fentanyl test strips. Just tell your patients to do that. And so this is the first I've actually even heard that you can't access them in Texas. And so that's great to know for our medical providers when we're doing this education, because it's great if I say that to somebody and then they go find out later, oh, she doesn't know what she's talking about. I can't get those.
Can't access those. Yeah, and hopefully it'll be very soon that we'll get access to this. Another thing I wanted to mention was, when you talk about fentanyl, we always talk about overdose. Mm-hmm. And so one of the laws that got passed in the past couple of years, which has been critical, is now fentanyl overdoses are considered poisoning. And it seems like a very minute difference, but because it's considered a poisoning, we are able to prosecute those that are distributing these fentanyl-laced products. If it's an overdose, you can't prosecute the person who distributed it. But if it's considered poisoning, you can prosecute them. So that's a huge win. And now again, local, state, nationally, we can go after the people that are distributing these illegal medications.
Well, that's really good to know as well.
Absolutely. Yeah. I mean, I think it's so amazing that even the reversal agents are available over the counter now.
Yeah. And that took legislation too, right?
Yep.
Thankfully, that passed a while ago. But again, it took a push from the physicians and the TMA and everybody involved to get that pushed through, because before it was so hard to access. And I remember before that got passed, I would prescribe all patients that received opioids from our practice the prescription version of naloxone or Narcan, the nasal spray, but it wasn't always covered by insurance. And the delivery device was unbelievably expensive if you paid over the counter. So we would send in a prescription and a lot of patients wouldn't be able to get access to it. So it's great that they are able to now.
Yeah, and it's become such an issue that on July 11th, 2023, the White House released a national response plan to address the emerging threat of fentanyl mixed with another drug called Xylazine. Will you speak to that a little bit, Dr. Yazdani?
Sure. So xylazine is actually a veterinary medication, and it's used as a tranquilizer in veterinary medicine. It's in a class called alpha 2 agonists. And in humans, in the anesthesia world, we use a medication called dexmedetomidine, which is an alpha 2 agonist to sedate patients. And again, medical only, certainly in the operating room, for example. But xylazine has been increasingly found, unfortunately, mixed with fentanyl and other medications and these illegal medications that are being manufactured. And it's very potent, especially when combined with fentanyl. So, fentanyl by itself, as you mentioned, much stronger than heroin and morphine. Now you mix it with another sedative, and one plus one does not equal two, it equals five or six.
Wow.
And so that's what happens with xylazine is you can get it. And in fact, I mentioned it's a veterinary tranquilizer. The street name, one of the street names is Trank for it.
Mm.
And so people will get this as a sedative and they'll, people that are distributing these will lace it with fentanyl. And one of the wild things to think about is if you think, okay, if you were distributing these drugs illegally and you're lacing it with fentanyl and your patient, not your patient, your purchaser dies from it, you would think it would decrease the likelihood that you would continue to lace your products with fentanyl or xylazine. But in fact, the opposite is true. So when the people that are addicted to these medications buy these illicit substances, if the person they're buying them from has a street reputation that people are dying from their medications, the value of those medications goes up.
Wow. Why?
Yeah, because they believe that the closer you get to death, the more high you'll get.
Oh my gosh.
Wow.
And which is absolutely counterintuitive and wild to think about. But they look for the dealers that have the most potent medications, and if they have people that are dying from those medications, they think, oh, they've got really good medication. I need to buy it from them.
Well, and there comes the
Which
business aspect. You've now got supply and demand, and so we're just continuing to create this industry, right?
absolutely, and the industry is also rampant because making these medications is easy. You can buy a pill press on Amazon,
Oh my
and
gosh.
the drug labs that they've busted, the pictures you'll see, there's all kinds of white powders around. Is it fentanyl? Is it heroin? Is it something else? Who knows? And obviously it's not a pharmaceutical lab, right? So it's just everywhere. It's not scientific by any means. In fact, there are case reports of police officers when they go in becoming sedated from just the powder being in the
Mm-hmm.
air. And so now they have to wear special protective gear to protect themselves from that. And then because it is so uncontrolled, the amount of fentanyl that's in a tablet, and they've studied this. So in medicine, for example, right, when we sedate patients with fentanyl, we give 50 micrograms in 1 milliliter. So we'll give 50 or 100 micrograms. In illegally manufactured fentanyl, the dose can range anywhere from 2 micrograms, which probably won't have any effect at all the way to 2,000 micrograms.
Oh wow.
And each pill, because it's so uncontrolled, you have no idea. You could get 5 pills from the same dealer, and one could have 20 micrograms and one could have 1,500. And so you take one and you get an effect and you don't die. And then the next time you get poisoned and you die. So,
And I think one of the things that people don't think about, especially our young people or people who maybe do partake in, we'll just say illicit recreational drug use, right? They say, well, I've taken pills, I've taken, ecstasy or something like that, or I've bought some Xanax from somebody and I've never had an issue before. I'm not trying to buy fentanyl. Well, they don't realize that lab, like you're saying, they can be making your Xanax, and they can be also making your, let's say putting together your ecstasy in your little packets and things like that. But there's cross contamination, which is us in the science world. We know all about cross contamination, but the layperson doesn't realize they're not getting a FDA approved, fact check, wearing gloves, expertly sorting it, expertly measuring and weighing it appropriately. We're talking about people that don't really care how they do it. Like you said, it's a mess when they go in there. Some people may also be partaking in the drug as they're making it as well.
absolutely. And I would compare it to, when you go to a restaurant, sometimes they'll have a warning on the menu that, there may be certain allergens in our kitchen that even if if you don't order a peanut based dish, well, the peanuts may be around somewhere and somebody might have touched one. And so just like you said, similarly in these labs, you have no idea what you're getting with these medications.
So, what are the signs and symptoms of a potential opioid overdose?
So usually it starts with sedation, drowsiness, lethargy. It can continue on to confusion. We always talk about the pupils, right? Looking at small pupils, pinpoint pupils, those are a sign of opioid overdose. And then eventually, your breathing starts slowing down because that's what these opioids do at large enough doses. And then ultimately, those patients stop breathing. And that's what leads to the death. In between, you may have nausea, vomiting. They may make strange gurgling noises. So if you see somebody who looks like they're confused, halfway passed out, making those noises, in this day and age, unfortunately, fentanyl overdose should be pretty high on the list of things that could be causing that.
So, what should be done for somebody with signs or symptoms of a possible opioid overdose?
So calling 911 obviously is number one. So definitely need to do that immediately. And then go to the person, try to arouse them. We always in medicine, right? Sternal rub, things like that. Call out to them, see if they're responsive. If there is naloxone or Narcan available, then administer that immediately. Most of the nasal sprays are very easy to use, and you just administer it in one nostril, and hopefully that reverses any opioid that they have in their system. Even if it's not an opioid overdose that's necessarily causing it, the risk of naloxone causing an adverse effect in that person is very low, very minimal. And so in the field, EMS, when they go out there and they find someone like that, that's one of the first things they do. And now police officers are carrying naloxone with them. If they find someone, they'll reverse it. And then it's critical to stay with that person too. As they come around, you don't just assume, okay, well, the ambulance is going to come take care of them, I can leave. Naloxone has a very short half-life. And so depending on what opioid they overdosed on, if it's fentanyl or something else, or mixed with xylazine, as you mentioned before, sometimes that can outlive the naloxone. And
Right.
so if they start getting sleepy again, then you need to re-administer it. And naloxone being available over the counter, you mentioned, is nice because it sometimes comes in 2, 3, 4 packs. So you can have multiple doses available because the one dose may not be enough to save their life while healthcare professionals arrive on the scene.
So where do I get naloxone? Like we say it's over the counter, but is it over the counter? Do I need a prescription like written out and saying I'm allowed to go get as much as I want, or how does it work?
No, so it's behind the counter
Okay.
still. And so it's not just on the shelf. And so you're going to have to go to the pharmacist and ask for it. Once you ask for it, then they'll have it available at almost all retail pharmacies, Walgreens, CVS, Walmart, all of these places. And it's fairly inexpensive. It's about $30, $40 for the dose, 1 or 2 doses of it. But again, it does require you to go and ask for it, which hopefully with more education to the public about this epidemic that we're having, it lowers the barrier to access. Because previously, if you went to a pharmacist and you were asking for naloxone, something would pop up in your head. Oh, am I going to sound like a drug addict because I'm going and asking for this medication? But no, being it over the counter has been incredibly helpful. I'll tell you one interesting example that thankfully the over the counter access has eliminated. I've had 2 patients in the last 5 to 10 years, I would say, who I prescribed naloxone to, the prescription version, because they were on an opioid as a safety measure. They actually got denied for life insurance because when they
Wow.
pulled their pharmacy records, they saw that they had a prescription for naloxone and they thought that, oh, this person must be addicted. That's why they've got this prescription. And they didn't. And I had to write letters to their insurance companies just explaining the situation, which is wild. I never thought I'd have to do that. But thankfully, the over the counter access has eliminated that problem.
So we're kind of trying to deal with both a stigma associated with it as well as access. So we've got 2 problems that we've got to deal with that. Absolutely. So this information can truly save a life. So we really appreciate you delving into this subject with us.
Absolutely.
All right, switching gears here. I want to focus now on how we can prevent some of these tragic stories we hear about in the news. Dr. Yazdani, what can we do individually or as a community to fight back against this epidemic?
Some of the things we've already mentioned, right? Education not only to our family, our friends, our loved ones, our patients, our children, also in schools. Getting access to test strips, hopefully, in the near future. Those are huge ways to fight this. And then just other things that we can do as physicians and as prescribers are prescribing opioids as safely as possible. we all know how the opioid epidemic started in the 90s with OxyContin. I'm sure we've seen Dope Sick and all the other documentaries that have dealt with that. And so for the people that don't know the background, in the 90s, Purdue Pharma was marketing OxyContin, which is obviously a very, very potent opioid, as just a cure-all, essentially. They were saying it's not addictive. It's going to really help your patients out. And back then, that's when pain became the sixth vital sign. And so that became really problematic because in theory, it sounds great, but then patients were showing up in ERs and urgent cares and primary care clinics. And in the ER, you weren't allowed to discharge a patient unless their pain number was below a certain scale. So if they said, I'm in 8 out of 10 pain, you were not allowed to discharge that patient. And if you did, that violated the hospital policy. And then obviously it affected, unfortunately, we do, look at patient satisfaction, Press Ganey scores, all those kinds of things. And if you've got somebody who's demanding an opioid and you don't give it to them, they're going to give you a poor score. So all those things just combined led to the prescription level epidemic. Now it's shifted a little bit, right? So now we're talking about illegally manufactured fentanyl. And they've studied this, and we talk about this at the Texas Pain Society meeting every year, is that over the last 5 years, opioid prescriptions have dropped dramatically. It started in 2016 when the CDC opioid prescribing guidelines came out, which a lot of folks criticized because they may have been a little bit too restrictive and people got scared and maybe were dropping patients on their opioid doses too quickly, which can lead to adverse effects, obviously. But as opioid prescriptions have dropped, opioid overdose deaths have continued to increase. And that's all from illegally manufactured fentanyl. So as prescribers, I think we're doing what we can to decrease opioid use, and we're doing a good job at it. But really curbing the illegally manufactured fentanyl is going to be the most critical component of getting rid of this opioid epidemic.
Absolutely. And in trying to decrease that, what are some of the alternative treatment options to opioids for like an acute injury or in the post-operative recovery period?
So post-operatively, we always use the term multimodal analgesia, right? So that means that we're using multiple modes to treat pain, not just opioids, right? So after you've had surgery, you don't just go home with the prescription for opioids and that's it. If appropriate, a non-steroidal anti-inflammatory use can be incredibly helpful. They have IV versions of NSAIDs now that you can use. They've got IV acetaminophen that we're using in the operating room to reduce pain, muscle relaxants, and then adjuvant therapies like epidural blocks, spinal blocks, peripheral nerve blocks. All these things have helped tremendously. For example, knee replacements, one of the most common surgeries performed in the United States. Before you got a knee replacement, you went to recovery, they kept you in the hospital for a couple of days on a PCA and then sent you home with a long prescription of opioids. That's how you got through the post-op recovery period for a knee replacement. Now, we are putting in spinal blocks. We're putting in peripheral nerve blocks. There are long-acting local anesthetics that can last up to 72 hours that you can inject. There are even catheters that you can send patients home with where you put the catheter into a peripheral nerve that's going to block the pain from whatever surgical site, whether it's a knee or anywhere else. And then they go home with it. And then after 3 or 4 days, they can take it out themselves at home. So they have things like that. Physical therapy, acupuncture actually has a lot of good data behind it as well, which is wonderful. Compounded creams, cognitive behavioral therapy, all these things are non-opioid treatments that can really reduce pain. Now, if you had a major surgery and you do all of these other things, you may still need an opioid temporarily, and that's okay. That's one of the appropriate uses. Cancer pain, certainly. Right. We always talk about patients that have cancer pain and the WHO ladder, which is from the 70s, but it's still around and we're still using it in terms of treating cancer pain. So cancer pain and opioid use is perfectly appropriate and justified. But with cancer patients, even, you have to remember that our cancer treatments have advanced dramatically over the last few decades. And there are so many patients now with surgical treatments, chemotherapy, radiation, other adjuvant treatments are getting to what we call NED, no evidence of disease. Now, of course, they're still going to get screening because you can have recurrences, you can have secondaries that form and all these kinds of things. But once that patient is to no evidence of disease, then it's critical to start weaning the opioids that they were on. Now, there are, of course, chemotherapy-induced neuropathies, for example, other treatment-related adverse effects that the patient may have to live with the rest of their lives, which they may need opioids for, but they shouldn't need them at the level they did during active treatment and when the cancer was active and affecting their pain receptors. And so that's important too, is if you've got a patient that's no evidence of disease, to talk to them about, okay, well, you were on this dose before, we really have to slowly wean you off this in order to reduce your risk for opioid misuse, overdose, et cetera.
Yeah. And as a gastroenterologist, I'm going to put my PSA out there. If you are doing a pain regimen, make sure you're doing a bowel regimen.
Absolutely.
I see a lot of constipation related to pain medications, and I feel like it kind of gets overlooked sometimes. So just keep that in mind. If you're getting prescribed these pain medications, you might need to be on something to soften your bowel movements while you're taking them.
Absolutely. That's a great point. And I talk to patients about that anytime I initiate an opioid prescription. And as you said, there are over-the-counter medications that you can use to help with that. But the prescription medications are incredibly effective too. You've got all the peripheral opioid antagonists that you can use for the gut to help reduce the incidence of that constipation, because sometimes patients get in this loop where they'll start an opioid, they get constipated, they start getting abdominal pain. So they think, hey, I'm having more pain.
Right.
Let me take another pill.
Yeah.
And then that just makes it worse. And obviously can lead to all kinds of obstructions and perforations and things like that too, if it gets severe enough. So
yeah, and trying to convince someone that it is their constipation is tough. They're like, no, that's not causing this pain. I was like, no, it's really painful.
Yeah, absolutely.
Many of my patients suffer from chronic back pain related to things like degenerative disc disease, spondylosis, or osteoarthritis. What new treatments are there to manage pain? What else is out there besides maybe an opioid? Because especially some of my older patients, they maybe were of that generation several years back where they had that back pain and someone was really quick to just throw them on an opioid.
Yeah, that's a great question. So pain medicine has evolved dramatically, even in the last 5 years. The amount of treatments that we have available to directly treat the disease that's causing their pain have really exploded, and it's been a wonderful addition to our repertoire of things that we can use. Obviously, you start off with conservative care, as we mentioned before, right? Physical therapy, acupuncture, topical creams, anti-inflammatories, muscle relaxants, all those kinds of things. If you fail those, then at that point, you start thinking about getting advanced imaging, right? You get an MRI scan or a CT scan, and you take a look at where the pain is, what's causing the pain. And then you start getting into the traditional pain management therapies that we've had, corticosteroid injections, nerve blocks, nerve ablations, things like that. Should those fail, we typically, if it's spinal disease specifically, we typically get surgeons involved, right? Whether it's neurosurgery or orthopedic spine surgery, and say, okay, can you evaluate this patient to see if there is an option? And even in those options, people always get scared when you mention back surgery. I'm sure when you say, I'm going to refer you to a neurosurgeon, they say, oh, no, I don't want surgery. But yeah, and you have to reassure them that, hey, even surgical procedures have evolved dramatically. It's not what it was 20 years ago when you went in and everybody came out with an incision this large and a bunch of plates and screws in there. There are lots of minimally invasive spine procedures now, microdiscectomies, et cetera, that our surgeons can perform that help these patients. And a lot of those are outpatient surgeries. They'll take 45 minutes and you go home right afterwards. So if you frame it that way, then the patients are more likely to get an evaluation. That being said, not all patients are surgical candidates. Their disease may not be bad enough. They may have medical comorbidities that prevent them. They may have severe osteoporosis that prevents them from getting appropriate surgical treatment, in which case, we collaborate with the surgeons very closely on those patients. They may send them back to us and say, yeah, they're really not going to do well after surgery. The anesthetic risk of surgery may be too high, et cetera, because of cardiovascular risk factors. And so then they'll send them back, and then we start getting into our advanced therapies. So those include things like spinal cord stimulators, and now we've got newer therapies like dorsal root ganglion stimulators, peripheral nerve stimulators, interspinous devices, all those things that are kind of in between just getting an injection and getting open surgery. And so those treatments are the ones that have really evolved in the last 5 years or so. And every year, more and more companies are coming out with products that can help these patients. And so no matter where you are on the spectrum of disease, whether you're in the early stages or in the late stages, there is usually a treatment choice that's appropriate that will either reduce or hopefully eliminate the need for opioids. Now, of course, during the workup process, right, while you're getting the scans, while you're doing all those things, you may need to prescribe some opioids for patients, and that's absolutely fine. But once you've got the pathology identified and you've started appropriate treatment for it, then don't just keep them on that the rest of their lives. Say, okay, well, we've treated this now. Your pain has improved. Your function has improved, which that's another critical thing to look at. The numerical rating scale, the 0 to 10 scale, which I know we all absolutely love in medicine, is not great. We have to document it for certain insurance purposes, et cetera. But really, I would encourage everybody out there to look at different tools that measure function. The Oswestry Disability Index, the short form 12, things like that look at patients' activity level, their sleep quality, their quality of life, those types of things. That's a much more critical thing to look at than saying, okay, your pain was an 8 last month, it's a 7 today. That doesn't really tell me much about that patient. But saying, hey, I was able to sleep more. I was able to play with my kids. I was able to go and sit at my desk at work the whole day without hurting. Those are the kinds of things we really look at.
Oh, that's good perspective for sure. So let's say you are somebody who has chronic pain from perhaps a back injury that's not responded to any other form of pain management, and you do require an opioid long-term, let's say hydrocodone, throw that out there for pain control. What are some things your doctor may do to not only protect you from harm, but also themselves from liability?
So some of the things that we can look at doing are the current safe prescribing habits that are recommended for all prescribers, whether it's hydrocodone, as you mentioned, even tramadol, some of the less controlled substances going all the way up to oxycodone, morphine, Dilaudid, things like that. Is number one, you need to risk assess that patient. There are lots of easy risk assessment tools. The opioid risk tool, for example, is an easy self-administered questionnaire you can give your patient in the office, and that will identify risk factors for that patient's opioid misuse. And so risk stratifying those patients is critical in terms of what you prescribe them, and also limiting the amount and duration of the prescription. Previously, if somebody came in and then they said, oh, I'm hurting. So, okay, well, here's a month of hydrocodone, come back and see me. When I did fellowship in 2013, hydrocodone was still a Schedule 3, like tramadol is now. And so it was not uncommon to see a lot of people get prescriptions for 180 hydrocodone with 5 refills.
Wow.
And it was extremely common. And so when it became Schedule 2, obviously it restricted a lot of people from prescribing it. And then that's when, the pain specialist got flooded a little bit with all those patients that have been on these medications. And it was actually a huge challenge weaning those patients, because they do become psychologically and physically dependent on that medication. If you've been taking a hydrocodone every 4 hours for 10 years, it's hard to wean that, right? It's hard to say, well, let's get an MRI scan and find out what's causing your pain. Let's treat the pain and let's get you off this medication. And so it's been really challenging. And thankfully now we're really past all that. And I think we're more in control of those prescriptions than we were previously. So controlling the amount and duration, as I mentioned, pain contracts, right? So you have to have a pain management contract with that patient saying, hey, these are the rules. You've got to follow the rules. And the Texas Pain Society has a wonderful pain management contract available for free on their website for any providers that want to look at that and download it. And of course, you can edit it to fit your practice and your patients and your location to make it most appropriate. But those contracts have things such as, we don't do early refills. You have to come in X amount for refills. You have to get urine drug screens, which are another critical component if you have somebody on opioids, is to look at the urine drug screens and make sure they're taking those opioids appropriately. And even that, before, again, 10 plus years ago, we used the dipstick urine drug screens that were just point of care, that you would just dip that thing in their urine and it would tell you opioid positive or negative, and that's it. And so that was a standard of care back then. It is no longer the standard of care. Of course, it's a very good screening tool, obviously, but I would encourage everybody, for these patients, especially the ones that are on chronic opiate therapy, that you do, when you do screen them every once in a while, confirm it with mass spectrometry. So you can send it off to a lab that will actually analyze the urine, and then they'll look at which specific opiate shows up there, and also opiate breakdown products or metabolites. So if you have a patient on hydrocodone, for example, and you send it off for spectrometry, it'll come back with hydrocodone, norhydrocodone, and 4% of it goes to hydromorphone, which is Dilaudid. So some of it does require some research and education on the prescribers, right, to look at it, because if you have somebody on hydrocodone and they come up positive for Dilaudid in their spectrometry, you're going to think, oh my gosh, this person's taking street Dilaudid or whatever the case might be. But it's an appropriate breakdown product. On the other side of that, if you have somebody that comes up positive for hydrocodone and no metabolites, then that should be a huge red flag. And the patients, especially back in the day, we used to call them professional patients that would come in, and they would come into your office, and they were always people that you loved seeing. They would always show up on time, always pay their copay, always say, Dr. Gray, Dr. Sorrell, oh my gosh, I love your hair. You look great. And then, they would compliment you. And so it would really lower your guard. And they say, oh, my back's been really hurting. I need another refill on my hydrocodone. And they would go around doctor shopping, and they would go to 5 or 6 of these offices every week and get prescriptions. And the street value of hydrocodone is $1 to $2 a milligram.
Mm-hmm.
So if you get 120 10 milligram hydrocodones from one practice, that's $1,200 that you can sell it on the street for. And then they were going to multiple places and doing this. And when they would come in for their urine dipsticks, right, that was the standard of care back then, what they would do, very clever, they would just score off a little piece of that tablet into the urine.
Oh.
And then you would dip it, opioid positive. Oh yeah, they're taking their hydrocodone. That's fine. And if you got spectrometry on that, it would show that it's hydrocodone only, no metabolites, no breakdown products. So then you would know that patient is not really taking that medication, right? They're just doing that. Now, of course, they've gotten smarter, and they'll take a hydrocodone the day before their appointment.
I was
so
like,
okay,
there's ways around all these things.
Absolutely. And thankfully, doctor shopping has stopped because of the prescription drug monitoring program. So when that came out, it was huge. It was a huge win. It essentially allows you to look at a patient's fill history. All pharmacies are by law required to report within 24 hours of filling an opioid or any scheduled substance onto the prescription monitoring program. And now it is a requirement for all prescribers. Anytime you send in a controlled substance, you have to look at the prescription drug monitoring program. And thankfully, now our electronic health records, most of them have it integrated. We use Allscripts, it's integrated. Epic, it's integrated. A lot of them, it's integrated, where you can just click, it'll show up. You can even delegate it. You can go on the website and have a nurse or an MA designated to pull those up for you, just to reduce the burden on you, because you have enough things to do. And so they can pull it up for all your patients and say, Mrs. Smith was appropriately taking her hydrocodone. Here's her fill history on that. So that's really cut down. One of the things that is getting better is cross-state collaboration with this. So we're so close to New Mexico, being here in West Texas, it's important to make sure that when you are checking that prescription program, that you're checking the New Mexico box too, because it's very easy for patients. When I was in fellowship in Houston, it was critical to check patients getting fills in Louisiana. Because if you don't check those boxes, and you have to go on their website and put in your preferences, because let's say you're using Epic and you click it and your preferences haven't checked New Mexico, it may not show up. So New Mexico, Colorado, as many states as possible, it's very easy to check those boxes. Hopefully we're working towards a national solution for this, where nationwide, no matter where they get it filled, it will be reported on that. The other part of the prescription monitoring program is NARCS Care, which I'm sure you guys have seen. When you pull it up, the first thing that comes up is the NARCS Care score. Texas Pain Society and a lot of other societies have been fighting that to a degree, because the company that calculates that score uses a proprietary formula that they refuse to share with anyone. And so, you'll have a NARCS Care score of 400. And technically, if you look at the description, it says, patient has an increased use for opioid overdose, but you have no idea what went into that calculation.
Right.
Is it the patient's age? How many prescriptions? The morphine equivalents? We just don't know. And so that's a very tricky score to interpret. Not discounting it completely, but we really need more clarity on what goes into that score and if it's an appropriate and valid score. So we're working on that with the pharmacy board and the company that generates that score. So more to come from that down the road. So critical things for prescribers, just to summarize: check the prescription monitoring program, limit the amount and duration of opioid use as much as you can, regularly follow up with these patients, and get urine drug screens with intermittent confirmation with mass spectrometry.
Wonderful. And I think overall, what we've learned is responsible use and responsible prescribing of opioids is key to fighting back against this epidemic. Prevention of misuse and overuse can save lives. Thank you, Dr. Yazdani, for taking the time today to discuss this very important topic with us and our listeners.
We appreciate you having me, of course, and I hope this was helpful for all of our listeners, our patients, our loved ones, and our prescribers out there. So thanks for having me.
Yes, absolutely. Thank you for being here. Your insight is really invaluable. For our listeners, if you're ever in need of help with an opioid crisis, there are resources. Please see our show notes for a list of resources, as well as the national hotline that you can call for help. The number is 1-800-662-4357.
Don't forget, if you are a listener claiming CME credit, please look in the show notes for instructions.
And for all of our listeners, thank you for tuning in. Please like, subscribe, and share this episode. Let us know what other topics you're interested in through our Instagram, and stay tuned for our next episode.